He's still alive?
I'm sure he's still alive. I'll give him a call.
You know, when the trainee is not available, then
Yes, it gets.
the trainer takes
Oh,
over.
he's back. He's back.
He's back, yeah. Dr. Lampret, do you want to share your screen?
Hi, my sincere apologies. I seem to have disconnected for a split second.
No, we noticed.
I apologize for that. Share my screen with you in a second. Screen. All right.
Perfect.
Are you all able to see?
Very well. Go ahead.
Yeah.
Right. Good morning. Good afternoon, everyone.
Go ahead.
Thank you very much for your time. I really do appreciate it. Again, I'm Matthijs Lamprecht from Neurosurgery at Tygerberg Hospital in South Africa. Fortunately, this is not an emergency case, as per our previous Dr. Rojtowski, that I just wanted some advice on from the panel on how to approach this patient.
I think we're having a little bit of difficulties hearing.
Yeah, I think
Seems to be a communication problem.
Is David there?
I'm here. I'm not with
You're not
Matthijs.
with him?
No.
Do you want to?
I'm turning my video off to try and reduce any bandwidth problems.
Yeah, he disconnected. So maybe you can explain the case while we try to get him back.
Seems to have internet issues.
Yeah, poor man. Do you know the case, David?
I think we lost.
Can you hear me now?
So.
Yeah.
David is muted.
David is muted. Dr. Lamprecht, you're back.
I can give you some background and
yeah, go ahead, David. Explain to us why he tried to connect again.
So we have a 50-year-old female presents to her local hospital with a long-standing history of headaches. And these headaches are unresponsive to medication. She develops diplopia, particularly bad on left gaze. She's also developed discoordination. She's dropping objects, and she has some difficulty walking. Family and collateral give a history that she's struggling to pronounce words and not making sense from time to time. There's no background history of seizures or any other signs or symptoms. And these issues have been developing over the last 3 months. There we go. I see it's back.
Yeah.
Matthijs, do you want to take over?
Hi.
I think start on slide 3.
Sorry about that. Can everyone hear me?
Very well now, man.
Yes.
Okay. My sincere apologies. I don't know what's happening with our network. Thank you, Dr. Rojtowski, for the summary. Essentially a 3-month history of worsening diplopia, deep-seated headaches, and change in her coordination, and her family mentioning her pronunciation and articulation is different. And then that's how she ended up in our system. Just her relevant clinical findings. She had a dilated left pupil up to 6 millimeters with very poor response to light stimulus. Her consensual reflex was, however, preserved. Her visual acuity was unaffected, and on confrontation testing, her visual fields were unaffected. Her formal VA and VF are still pending as an outpatient. She had a left-sided lateral rectus palsy, with no other gross cranial nerve deficits. She had a dysarthria, a dysdiadochokinesia on the right-hand side, dysmetria, but the rest of her neurological examination was normal. So in summary, we're dealing with a left-sided cranial nerve 6 palsy associated with cerebellar signs, mostly affecting the right-hand side. Just going through the relevant imaging sequences, just to get straight to the point. On her sagittal, one can make out classical features of a meningioma extending from the clivus in the midline, displacing brainstem or midbrain and pons posteriorly, with some slight cranial extension, and involvement of various factors, which various other anatomical structures that I'll get into in a second. On the axial plane, one can make out some slight abutment of the fourth ventricle due to its displacement. Yeah.
And this patient, where is this patient right now?
She's currently at home. She's been discharged. She's coming back coming back to our unit for surgery, pending the decision at today's discussion. The one key thing I did want to show regarding this patient's imaging is in this slide, where one can see not only almost circumferential involvement of the basilar artery, but as well as encasement of both posterior communicating arteries. In summary, regarding her clinical examination, classical features of meningioma with no restricted diffusion and no blooming on SWI. Its superior margin, it extends into the suprasellar cistern. It abuts bilateral internal carotid arteries and displaces the optic chiasm left more than right. And as mentioned, it encases both PCOM arteries. Posterior displaces the midbrain pons with 270-degree envelopment of the basilar artery, and on the lateral aspects, it encases and thickens the left cranial nerve 6. The discussion for today and why I've decided to bring this case to the table is I require some assistance with the following questions regarding her goal for surgery. What are the targets for resection? The surgical approach, would the panel recommend an endoscopic transclival or a retrosigmoid with or without a Kawase or a subtemporal approach? Would you recommend it being staged or in a single sitting? What are the positioning considerations? And do you recommend any adjuncts or cranial nerve monitoring for this patient?
Yeah, while we discuss that, if you could go back to can you go back to the with contrast? Yeah, one of those. Yeah, this is good. We can leave it at the screen there. Dusik, what do you think, man? South Korea there, patient is home. What would you do next?
So I agree that we have two options. First one is endoscopy, endonasal approaches, because this tumor is not less involving the petrous apex. Most of the tumors involve the clivus and clival meningioma, and also I found that the T280 image is a very high signal intensity, and it means that tumor is relatively suckable tumors, and it's a good indications of endoscopic endonasal approaches. But the main problem my main problem is how to reconstruct after operations. This is posterior cranial fossa tumors, and it's very hard to reconstruct. And so, if you are not confident to the reconstruct after operations, and then maybe the retrosigmoid approaches may be better, because it's also the suckable tumor.
Yeah, Suichi, what do you think?
Probably I would operate on this patient via left combined transpitros approach. Mm-hmm. Well, like Dusik said, that the transnasal endoscopic approach is another very good option. But this patient is a 50-year-old, so we have to, secure their another 40 year. And so if you choose the endonasal approach, probably you can't take care of the whole dural attachment to repair the dura. So that's why I would prefer the combined transpitreous approach. That's probably guaranteed a gross total resection.
Yeah, very interesting. Francisco, I'm curious to hear your opinion.
To be honest,
Try to be
until
honest.
like 3 years ago, I will do it endonasal. But to be honest, in the end, most of the cases you need to combine then later with a retrosigmoid because you have to leave a little pieces. In this case, for example, in the left side. I think it's a good case for endonasal, but you have to be aware, and I'm agreed, the reconstruction is going to be a pain. And the time that you will spend in the surgery is going to be long. Nowadays, I am in a conflict when I see this kind of patient because I have a fine in my mind. I go endonasal and I go in a long surgery, or I do a posterior petrosal approach and take the tumor out. The last cases that I have like this, I am doing posterior petrosal approach, to be honest. Endonasal surgery in this case is going to be long. The reconstruction is going to have you some difficulties because you have more increase in CSF leak. You have to take care of a lot of issues in endoscopic, but it's a very good option. I don't abandon this option, but I'm aware that it's better to go petrosal posterior.
Sami, I'm curious to hear your opinion as well.
Yeah, I mean, you have to think of this tumor in relation to the neurovascular bundle and what's the safest access without dealing with so many cranial nerves. And I know in Japan, the combined petrosal approach is very popular. If you look at that line that nicely drawn along the IAC, so you see that there is just a little tumor below that line, coming subtemporal anterior petrosal approach, it gets you direct access, lateral angle, where the basilar is on the back of this tumor. You have this luxury of looking a straight, direct line behind the tumor and peel it off the brainstem, because that's your main goal here, is decompressing the brainstem. And when you come to the basilar trunk and you're seeing all these perforators, if you have an arachnoid plane and it's just pseudo engulfing of the basilar, that you can peel it off nicely in the arachnoid plane. If it's stuck, then you leave a shell of tumor on the basilar trunk. When we did the study that we published about the posterior petrosal with these cases, we found no advantage above the pontomesencephalic junction, which is the majority of this tumor is. So it gives you that narrow window through the facial and the lower cranial nerves to that anterior brainstem. And that's when we come endoscopic later, if we want to, like the patient is young and you have residual that is very central retroclival, then we would come transclival to get that part anteriorly to replace the posterior petrosal approach. If you think about retrosigmoid, I think retrosigmoid is the least favorable here. Is it a true petroclival meningioma? So you're going to be working through narrow windows through the nerves coming from a retrosigmoid to get there. Regarding the endoscopic by itself, I have to warn against the consistency of this tumor. We don't have really, we do the ADC map on these tumors and you can talk about consistency, but we haven't been successful. So going in endonasal first, you might deal with a very fibrous tumor. The basilar is on the back of this tumor. You have zero really ability to manipulate the line of sight to get to the basilar posteriorly, and the PCOMs, of course, on top. This patient have combined of 6th and 3rd nerve palsy, so there is some mass effect on the 3rd as well, on top of this tumor probably, because that's why the pupil is not that reactive rather than vision. So I think to summarize is anterior petrosal first, subtemporal anterior petrosal, and possible endoscopic for central residual.
Very good. Just to complement what you said, is nice publication from the Mexican team where they show if you try retrosigmoid on these very retroclival tumors, you actually don't have a good space to really take it and correlate with higher level of morbidity for when that was attempted. But I'm curious to hear, Linda, you come from a center that the combined transpetrosal is really one of the main tools there. Like, what do you think, in your opinion, about just an anterior petrosectomy for a case like this instead of doing the whole pre-sigmoid?
It depends on the veins. So the two sequences that I would decide on this particular case would be the T2 sequence for a suggestion of the texture and consistency, the firmness of the tumor, and number two, the venous study. And especially the pattern on the floor, the orientation of Labé, the potential dominant drainage along the middle fossa floor, because there are situations, as you know, that the veins may be less favorable for either subtemporal along the left side or for cutting the tentorium for the petrosal approach. So the decision for approach for this case for me is wholly dependent on the veins. I agree that this could be at least to prepare for potentially a more firm consistency here, at least on the contrast scan. There's not the extra knobby tooth and the sort of appearance that sometimes we see with the more invasive, PO invasive tumors. So if the T2 were favorable, meaning showing the suggestion of a preserved arachnoid plane, then it's really about the trajectory rather than thinking about the risks, again, the perforators. I think both, what Sammy said, or coming from the back, perhaps not even, because there's not really any extension of the tumor lateral to the tentorium in this case. So a pure posterior petrosal is a reasonable option here. And that gives you both the full skeletonization of the left transverse sinus to get that extra kind of straight trajectory going deep, as well as so you could have a retrosigmoid window or a pre-sigmoid window, depending on what one wants, or the cutting of the tentorium to allow things to open up more. In these types of tumors, I guess, with a clival origin, the fifth nerve is probably pushed upwards. So that coming from the middle fossa, that fifth nerve you might encounter that first before the tumor. This person, I think, has a third and a sixth nerve palsy, from what I recall. He said there was a dilated pupil. So those, the sixth nerve, regardless how you come at it, from the back or from the front, will be, I think, quite involved. But the third nerve may be more in the way a little bit, coming from the top as opposed to be at the back. So I think, but for me, the decision of the approach, posterior petrosal or a different coming from anterior would depend on the veins.
Yeah, I would like to mention that I agree with Sami with the idea that the pre-sigmoid, in my opinion, for this case doesn't help much, because you still have 7 and 8 in front of you, and you still have to work above and below 7 and 8, versus the anterior petrosectomy that you go from the top and you land it anterior to 7 and 8. I think that's what you meant, right, Sami? And then because there's no inferiorly, I agree with you. That's, for me, that's the one of the main corridors there. And I want to hear from Jumuto, because Jumuto worked with Dr. Kawazi for so many years. And what can you tell us, Dr. Muto?
Yeah, I think Professor Kawase will do the anterior transpetrosal approach only. Yeah, you can see the whole view. Yeah, I think so.
That's what you will do as well?
Yeah.
Good.
Let me excuse me, and let me just explain just one more. Okay, why I think I really need the posterior transpetrosal approach view is that it's not easy to find the 6 nerves in some cases. So if we open the posterior, the pre-sigmoid dura, we can see the root exit zone of the 6th nerve, and then we can follow it. And that will, increase the safety of preserving the probability of saving the 6th nerve. That's my opinion.
And I agree. Is now I'm gonna one thing that I've been doing now that I want to see what you guys think. So I agree 100%. I have difficulties to find the sixth nerve when I do anterior petrosectomy only. It becomes difficult. I find it, but sometimes at the end of the case, and I do a little bit of blind dissection. So I realized that actually I can do faster combining anterior petrosectomy with a retrosigmoid approach. So instead of drilling pre-sigmoid that takes time, a very quickly retrosig allows me to do the same. So I also found the 6 deep there. As you go below the tumor, as I work below 7 and 8 from a retrosig perspective, and also to find 4 posteriorly. And then those things, it helps me to identify, not as the main tool to dissect ventral to the 5th nerve, but to identify the cranial nerves for safety as well. So I actually been adding a retrosig that is the position I put lateral anyways. I put the patient lateral, so a retrosig is right there, and a pre-sig preauricular. Pre-sig, sorry, no, the anterior petrosectomy preauricular. So I combine a preauricular with a retrosig with 2 different incisions. I was doing with a combine with a very curved, as we learned from a combine approach, but I realized you can just do 2. So for the last few cases, I combine anterior petrosectomy with a retrosig, which is, I think is a good option. And we've done a few cases with a good resection. I want to see just since we mentioned that Sadir is still there, would you do endonasal here, Sadir? I know you're a very good endonasal surgeon there. What do you think?
So what I will do in this case is I will do first, we go endoscopic, endonasal, drill out all the bone, take out the tumor. If it's coming out, it's well and good. Not coming out, leave the posterior capsule around, decompress as much as possible, wait for 4 to 6 weeks, and then go transpetrosal approach.
Yeah, that's what I would do probably too in my reality here, Sadir. I'll go because, and I like the fact that T2 is so bright. Yeah, now, and I think Lila, what would you go endonasal here as well? I know you're so skilled endonasal.
To my own opinion, for this case, the decision depends on which approach the surgeon is more confident with. So as we usually work like transnasal surgeons, we had just 4 cases like this, and we did them endoscopic, transnasal endoscopic approach, but it was not a gross total removal of the tumor. So in this case, I think we will also start from transnasal transclavial approach, but of course with monitoring for third and sixth nerve and maybe for caudal group, I think. And before the surgery, we will prefer to perform CT scans to understand the anatomic variations of posterior clinoid, because you have to do posterior clinoidectomy in this case, and it is important to understand do they have some connection with medial clinoid or anterior clinoid. So yes, we will start transnasal, but maybe later we will see what we will have, and maybe we'll ask our colleagues from posterior cranial fossa department to perform retrosig. Or maybe, like in third-hour cases, we can follow up the patients, and we can decide in future what to do if we have tumor growth or if we have no.
Good. So now to finalize Dusik, I think we gave all the options, but I don't know if we helped the South African team there. We just spread the options through the fan. What would be your advice directly to Dr. Rojtowski and Dr. Lamprecht Dusik?
I think
to put all together.
Not transorbital though.
Yes, if possible, I'm gonna try to the transorbital approaches, but still, I think if the tumor consistency is very important issues. Yes. But this tumor is a very bright T2-weighted signal intensity, And I think that it's a very good options for me to select the Indonesia approaches. How about the Dennis? You tried to the anterior pituitary or Indonesia approaches?
Yeah. So I'll tell you my concerns on this case is actually the sixth nerve on the right side, the left side. It's what I'm more concerned with the endonasal. So what I would do is Brighton T2, and because most of the tumor is retroclival, because for petroclival meningiomas, I look at the percentage. If a lot is on the petrous surface, I would come with a petrous approach. But if most is retroclival, I actually prefer endonasal. So here, my concern is the sixth nerve. So I open below the tumor, and I actually open the CSF space below the tumor. So I do a very, very large clivectomy. And I think it's important not to be worried about CSF at that moment because you're more worried about the sixth nerve. Then I found the basilar in the back going behind the tumor, so I know the depth. If you open only on the tumor, you don't know the depth of the tumor, and you start debulking tumor without understanding the depth. So I like to see below the tumor, follow vertebral artery and basilar behind the tumor. And I also try to find the origin of six. Frequently, I see the six push down and ballooning below the tumor and not even through it. And that allows me then to safely go and debulk the tumor. Superiorly, I agree with Lila. This needs a transposition. Usually I do a hemi transposition in these cases. So most of the time I do on the left side because I do a hemi, and then my left hand, I can lift the gland with a suction, and I can actually do a dorsum resection and also a posterior clinoidectomy and go in the higher part of the tumor. Because if you go back in the sagittal, you see a lot of the tumor is behind the pituitary stalk. So it goes quite high there. So if you look at that right there, yeah, see how, so I would plan to mobilize the pituitary gland to go behind there. And I remove as much as possible. And then I agree with everything was said. And then my second best here will be probably in the surgery, I'm trying to remove everything. But if not, I want to make sure the lower part is removed. Because as Sami said, then I can come with anterior petrosectomy for residual lateral on the left side. But if I have to do this without the endonasal, then I combine with the retrosig, as I mentioned earlier. So I would say now I guess what we should do is to hear from David. You know, if you have any other question, and Dr. Lamprecht, you know, what your thoughts, and do you think this was helpful? And let us know.
Just for the monitors part, because we haven't discussed that. So I would monitor 6, 7, and 8, and I rely on 8 for the bear for the brainstem, just to give that also.
Yeah, bilateral 6, right?
Yeah, well, if you're coming endonasal first, then you do
Yes.
bilateral 6.
Yeah.
But if I'm coming anterior petrosal first, then I will do unilateral.
Yeah.
For the monitoring for this, if coming from a transcranial approach, I would monitor 3, 5, 6, 7, 8, and do cortical bulbars specifically for 3, V3, 6, 7.
Sounds complete. David.
Yeah, well, thank you. And Matthijs Lamprecht, thank you very much for putting this case together. I think as we see the diversity of views shows the potential complexity that there's no clear answer. I must admit my reluctance for an endoscopic approach here was because of my sense that this may be too firm a lesion to resect on top of a very difficult closure. So initially I had an intention to approach this open cranial predominantly through a petrosectomy, anterior petrosectomy. But given everybody's views here, I'm reconsidering that approach and considering whether the inferior aspect of it is better served with a transnasal approach and the clivectomy. But I'll have to keep you informed as to how we proceed.
And Dr. Lamprecht, do you have any other last thoughts in your perspective?
Not from my side. I think as Dr. Witowski said, our the data prioritize it. It gives credence to my question. But I found the input, especially the input on which nerves to monitor, very, very helpful. Thank you very much.
Yeah. No, thank you, everybody. I think since we're almost 10 minutes after the hour here, I'd like to thank everybody. I think this was very helpful. And I think the beauty of this group is that we try to really bring a reality to different scenarios, you know, around the world. What is available is not the same for everyone. I can see this being done in places where monitoring, for instance, is not available, or you don't have an ENT to work with you to help with the reconstruction. So all those things may change the way we make decisions in order to get the best results for our patients. So with this, I would like to thank everyone and really appreciate all your presence today. We will get the recording from today, and we will upload it in our YouTube channel. So thank everyone, and I'll see you next month. Thank you.
Thank you.
Thank you.
Thank you. It
Thank
was a
you.
pleasure. Thank you.
Bye.
Thank you.
Bye.
Goodbye.
Thank you.
Thank you very much. Goodbye.
Nice weekend.